I love the title. You know, Suzanne has a fantastic title here. So for those of you that do not know Dr. Mazhuvanchery, she's one of our current sleep medicine fellows. And her talk here is very timely given the state of our behavioral sleep medicine program and our lack of a sleep psychologist. It looks like she's going to be giving us all the tips that we need to manage our patients in our sleep clinic. So Suzanne, take it away.
Thank you. So good morning, everyone. So yes, the title, no sleep psychologist, no problem. So by no means am I trying to diminish the value of our sleep psychologists. I got to work with Dr. Landis a few weeks ago, and she has an tremendous amount of knowledge. So the purpose of this talk is mainly to give physicians more confidence. Well, let me step back here. First of all, I am no expert, so I will gladly take criticism, instruction from any of you that have more expertise. But I think it's really important that as clinicians, physicians, we at least try to do some CBTI in our clinics and not just easily refer patients to a sleep psychologist. Because at least in the pediatric clinics, we do this a lot. You know, we kind of start the prep work. So they're working with something before they actually end up seeing Dr. Landis. So I think whether you don't have a sleep psychologist or you do, it's always good to be comfortable enough to do some form of CBTI in the clinics. So these are our learning objectives. Is this working? There we go. Okay. So just some background. I became interested in sleep medicine in my first year of residency. So I got to shadow our sleep doctor during my second year. And obviously there's plenty of sleep apnea patients, but the insomnia patients were the challenging ones. And I even hear, you know what, whenever we get an insomnia patient, everyone rolls their eyes and like, oh my gosh, it's going to be a long visit. But it's very important that we be equipped properly with managing insomnia because, you know, 35% of the population, according to some statistics, do show that they have insomnia. So it's very relevant at this time. And also with busy practice, it's not easy to put in all the time we properly need to put in to manage insomnia patients. But you know, being comfortable with at least a few skill sets can really take us far. Okay, so I do not have any conflicts of interest, no financial disclosures. Okay, so what is insomnia? We all know this. It's a disruption of our normal sleep processes. So whether that's trouble falling asleep, staying asleep, or having early morning awakenings. But, and then I'll go through the ICSD 3 criteria later on, but you also need to have associated daytime dysfunction. Why do we care? The quality of life of patients who suffer from insomnia is very poor compared to people who don't. So about 22% of those who have insomnia rate their quality of life as being very poor, as opposed to only 3% of the normal population. Annual costs, whether with healthcare, incorporating for accidents, workplace absenteeism, all of that roughly estimated to be $35 to $107 billion a year. Patients who are individuals who suffer from insomnia, they miss work twice as much as other people, and they can also die. Now, obviously there is the fatal familial insomnia, so those people eventually end up dying. There was a study that didn't show an actual increase in death among insomnia patients who had insomnia for a 6-year period. But there was another study later on that I found from 2015 that did report that persistent insomnia was associated with increased risk for all-cause and cardiopulmonary mortality, and was also associated with a steeper increase in inflammation. So that's why I kept death on there. Other reasons why we care. It's associated with hypertension. Emotional instability from insomnia can end up leading to mood disorders, primarily anxiety and depression. So these are all things that are important. There's acute insomnia, there's chronic insomnia. Acute is less than 3 months of duration, usually stressor induced, whether that's physical, psychological, psychosocial, or interpersonal. Most of the time, a lot of folks, the stress is either eliminated or they end up adapting. But others, that initial stressor can end up leading to chronic insomnia. The differential. These are the things that come to my mind initially when I think of insomnia. So do they have restless legs? Is it undiagnosed OSA that's waking them up in the middle of the night? Circadian phase disorders, whether advanced or delayed, can sometimes present as insomnia initially. Chronic sleep insufficiency. So insufficiency has to do with not enough opportunity to sleep. Insomnia patients, they have the opportunity to sleep, they just can't sleep. Short sleep duration, those individuals don't have any daytime dysfunction, whereas insomnia patients do. And so these are some additional differentials or comorbidities that can exist with insomnia. So CHF, heart failure, COPD, asthma, especially in children, we see this. The nighttime asthma wakes them up. Stroke patients, Parkinson's patients, commonly we see them with insomnia, acid reflux, diabetes, RA, sleep apnea, we know. Nightmares, REM behavior disorder. This is just some sampling list. And obviously some of our psych conditions, medications. Not on this list are diuretics. I think that's very important. People who are on diuretics are constantly waking up in the middle of the night, having to use the bathroom, and then sometimes unable to fall back asleep. Also exercising too late in the night can end up causing trouble or difficulty falling asleep. Patients take pre-workout. They don't realize how much caffeine is in it, but that can keep them up. So the focus of our talk, the treatments that we'll be talking about, have to do with treating chronic insomnia. So that's primary, and that's divided into primary, secondary, and comorbid. So within primary insomnia, they come from different categories. There's psychophysiological, so people that have heightened arousal and then learned sleep preventing associations. These individuals actually would be able to sleep in a new environment or fall asleep when they're not trying to. Then there's idiopathic insomnia, so insidious onset occurring during infancy or early childhood. Sometimes this is genetically determined, or there are congenital aberrations in the sleep-inducing or arousal systems in the brain. Paradoxical, aka sleep state misperception. So this could be due to altered sleep-wake arousal system, inadequate sleep hygiene, and behavioral insomnia of childhood. Secondary insomnia has to do with some other mental disorder, a medical condition, or substance abuse, some other medications, even sometimes after the medication is off. So in our ICSD-3 criteria, all of these following factors need to be met. So in category A, the patient has to report one or more of the following issues. So like we talked about before, the difficulty initiating sleep, maintaining sleep, waking up earlier than desired, the resistance to going to bed at an appropriate time, difficulty, and this is related to children, difficulty sleeping without a parent or caregiver present for intervention. And they also need to have daytime dysfunction. So that could be range from any of these 9 things: fatigue, impaired attention, impaired social performance, academic performance, mood disturbance, irritability, behavioral issues, hyperactivity. We see that a lot in kids, reduced motivation, initiative, accidents, prone to accidents, and then they're just very dissatisfied with their sleep. So poor quality or unrefreshing, non-restorative sleep, they don't actually suffice to define insomnia disorder when occurring as the sole sleep complaint. And so additional criteria, the reported sleep-wake complaints, they cannot be explained purely by inadequate opportunity, so the time allotted for sleep, or inadequate circumstances for sleep. Sleep disturbance and associated daytime symptoms occur at least 3 times a week. The disturbance and associated daytime symptoms have been present for at least 3 months. And then the sleep disturbance and associated daytime symptoms are not solely due to another current sleep disorder, medical disorder, mental disorder, or medication substance use. So that's where when we see a patient, we take a good history and we have to filter out all those things. So this is just an infographic that I found online. Okay. So when we talk about insomnia, it has to do with sleep. It's good to understand how sleep is regulated. So we have our 2-process model of sleep regulation. You have your homeostatic sleep drive, your circadian drive. So a lot of us are probably familiar with this image. So as the day goes on, here we go. Where's this mouse? Okay, here we go. This is, sorry, okay. So we're very alert at these points of the day, and then we get a final peak here, and then the homeostatic sleep drive decreases this way, and the circadian decreases this way. So naps definitely will dampen our sleep pressure from bedtime. Unstable wake-up times will give the brain a confused time sense in relation to a regular, predictable sleep. So folks who try to sleep around, let's say 7 or 8 here, they won't be able to. They shouldn't be able to in normal circumstances, and so they'll get frustrated. Continuous sleep will be more likely if bedtime is delayed, to push the 2 sleep propensities together rather than letting them drift apart. So, like that. Okay. So this is from a paper by our Young and Dr. Spielman. Spielman is the one who came up with the 3P model. So there's the neurophysiological system, so our homeostatic, circadian, and arousal system. And then you also have psychological behavioral factors, so sleep cognition, behavioral practices, emotional arousal, and all of those things will affect sleep. So under the neurophysiologic models of insomnia, the homeostatic system increases the drive to sleep with increasing hours spent awake. Circadian process generates a biologic rhythm of sleep and wake tendency over a day. Arousal system promotes wakefulness in opposition to the sleep drive. And let's see here. Yeah. That again, so sleep cognition. People tend to have worries, traumatic events, even really benign things like you're just planning your day or you're really excited for your trip coming up. Those types of things actually can inhibit sleep due to an excessive cognitive arousal. So poor sleep, and so once you have that, sometimes, you know, you'll end up, not everybody, but a lot of folks will have poor sleep. Then after a night of poor sleep, they are, you know, people are ruminating over, oh my gosh, my daytime dysfunction, blah, blah, blah. Oh, the next night is going to be, I'm going to have another unsuccessful night of sleep. And then this cycle will then perpetuate. So even after the initial trigger has resolved, these folks can still have insomnia. So the dysfunctional sleep cognition can also lead to maladaptive behaviors that lead to poor sleep. So those are factors that are important to address in clinic. And again, it's the same image. So maladaptive behavioral practices. So, and this is divided into how they affect the different neurophysiologic categories. So practices that reduce homeostatic drive at bedtime, insufficient activities during the day. You can see this in elderly patients, you know, they are not as active as before. Those who lie down to get rest during the day, napping, dozing off, spending too much time in bed, and extra sleep on weekends can all be bad habits that can disrupt our normal rhythm. Practices that disrupt circadian regularity, insufficient morning light exposure, leading to a phase delay in circadian rhythm. And then early morning light exposure, producing early morning awakening, owing to a phase advance in circadian rhythm. And of course, irregular sleep-wake schedules, sleeping in the mornings during weekends. So it's really, so obviously in our repeats clinic again, you know, we always tell patients, you shouldn't be sleeping, whatever time you wake up on the weekdays, you should wake up no later than 2 hours from that time on the weekends. And then practices that enhance the level of arousal, so excess caffeine consumption or caffeine later in the day, smoking in the evening, alcohol consumption in the evening, exercise in the late evening, and late evening meals and fluid intake. And then practices that enhance the level of arousal, getting home late or insufficient time to wind down, apprehension of sleep, no regular pre-sleep ritual, distressing pillow talk, that all can do it. And this is a long list. You know, trying too hard to sleep, staying in bed during awakenings. Okay. And then, so sorry, going back. So we talked about sleep cognition, the maladaptive behavioral practices, and you have the emotional arousal. So poor sleep is expected when individuals are under acute environmental stress or emotional turmoil. As the autonomic nervous system and the hormonal system react to strong stresses or emotions, these physiologic processes may disrupt normal sleep mechanisms. So cognitive reactions to stressful and emotional situations, such as ruminating, worrying, may interfere with sleep further. So studies on personality traits, this is I found interesting, in insomniacs have reported that individuals who tend to internalize conflict through self-inhibition, denial, or suppression seem to be more susceptible to insomnia. Other psychological factors such as perfectionism, the need for control, excessive worrying, depression have also been found to be associated with insomnia. And arousal at bedtime also can be a learned response. So the repeated experience of poor sleep promotes association between sleeplessness and pre-sleep activities and the sleep setting. So when these connections are established, the bedtime rituals and environment become contextual cues for arousal than for sleep. So this is a visual of Dr. Spielman's 3P model, development model of insomnia. So you have factors that contribute to insomnia, and they're divided into predisposing, precipitating, and then perpetuating. So predisposing, we can't do much about that. We won't be targeting that much. You know, that could be genetics. Then there's the precipitating factor. So those are events that actually precipitated a sleep disorder. Even that area, we may or may not be able to do much about. But the perpetuating factors, the things that are still ongoing, which are like attitudes and practices that perpetuate the problem, the insomnia, that's something that we would target. So when we take a history, it's important to think of these different categories of factors and then try to target what we have control over. So another way to look at it, so predisposing factors that affect the homeostatic process. Those are abnormalities or weakness of the neurophysiologic system that generates sleep. The factors that, predisposing factors that affect the circadian process, extreme circadian type. So like your night owls that are predisposed to the late evening, or larks who are inclined to the early morning as an individual trait. And also individuals who are less flexible, who have a less flexible circadian system. Predisposing factors that affect the arousal system. So those, and we kind of talked about this earlier, anxiety prone and depressive personality traits, and tendencies toward neuroticism and somatization led to a higher level of emotional and physiologic arousals. So personality traits associated with sustained level of arousal, such as perfectionism and excessive need for control, heightened or more sensitive physiologic arousal system. So, you know, personalities, we can't change someone's personality, but it's important to acknowledge that this could be one of the reasons why they're predisposed to the insomnia. And then you have the precipitating factors affecting homeostatic process. So lack of a decrease or of daytime activities such as retirement, as mentioned before, circadian process, the people who have the change of the sleep-wake schedule, jet lag, starting of night shift, life for the precipitating factors that affect arousal system, life stressors or events, lead to emotional and physiological distress. So again, regarding the lack of daytime activities, that's something that we actually could target in patients. But you know, someone who has a night shift job, you know, parents, sometimes one person works days, one person works nights because someone has to be with the kids. Unfortunately, we can't tell them, hey, you can't work day shift, or you have to work day shift, because they may not have enough, they may not have a choice. And then perpetuating factors. So perpetuating factors that affect the homeostatic process, increased resting in bed, discharge of the sleep drive by sleeping outside of the nocturnal sleep period, such as daytime naps or frequent dozing offs, reduced daytime activities, perpetuating factors that affect the circadian rhythm. So sleeping in during the weekends to catch up on sleep, that can definitely end up causing a delay or causing an issue. And then perpetuating factors that affect the arousal system. So dysfunctional beliefs and attitudes about sleep that lead to increased emotional arousals and worries over sleep loss. And then also conditioning between bedtime cues and arousal. So I'm not going a lot too detailed in the pathophys because the focus is really more treatments. But we do see that increased physiological arousal across sleep and wakefulness from heightened sympathetic nervous system activity, and then our HPA axis. And then you also can see sometimes brain lesions in insomnia patients with comorbid neurological disorders like stroke, MS, and TBIs. So let's see something here. Okay. And along with that, these are the different physiologic changes that you'll see. You can see increased heart rate, altered heart rate variability, and elevated cortisol levels, increased body temperature. You can also see a high increase in high frequency EEG activity during non-REM sleep. So these details, they're from a few studies or limited studies, so that's why the small sample size, not necessarily always reproducible. But from other readings that I did, there were some studies that showed on functional neuroimaging, insomniacs showed increased cerebral glucose metabolism both during sleep and wake states. And then on EEG, those with insomnia demonstrated increased beta activity and lower delta activity. So I found that to be interesting. So now we went over, what is insomnia? What are the different pathways to how people can become an insomniac? So when they come into our clinic, we have to do a complete, a really good intake. So obviously, what's their chief complaint? What are their daytime consequences? What was the circumstance of the onset and the course of the insomnia? What is their schedule? So we would give them a sleep diary at some point, have them fill it out. Maybe if we have actigraphy, not every institution has access to that. That will give us more information about what exactly is their sleep schedule. Because patient can report one thing, but then we can see something else. So it's important that the story aligns to reality. Then we should also take the time to really understand what are their beliefs about their sleep problem, and what are the compensatory responses that they're doing. Do they have other sleep disorders? So, sometimes we do have to rule out sleep apnea before we do advanced therapy. Taking good medical history, medications that they're using, substance use, effects of prior treatments, what have they tried in the past, family history, and then assessments of their psychological and social functioning. So now to treatments. The gold standard. What is the gold standard? CBTI. So CBTI has a few different components to it. It's sleep hygiene, stimulus control, sleep restriction, relaxation, and then cognitive therapy. So we have our AASM clinical practice guideline, and CBTI is the only strong recommendation for a non-pharmacological treatment method for insomnia. And they made this recommendation based off of many large randomized controlled trials, about 49. And it's also important to note that these studies, when CBTI was administered or delivered, it was done by trained professionals. Yes, trained professionals. So when they did the meta-analyses to come up with this report, they looked at different critical outcomes. They looked at remission rate, responder rate, sleep quality, sleep latency, and then wake after sleep onset. And they also subdivided the insomnia patients. So there were insomnia folks that didn't have any comorbidities, those who had comorbid psych conditions, and then those who had comorbid medical conditions. And they only found clinically significant mean improvements they found actually clinically significant mean improvements in all three groups. All three groups showed improvement in the remission rate, responder rate, but only those with psych comorbidity or without any comorbidity did they see individuals who have an improvement in their sleep quality and sleep latency, and then their wake after sleep onset. I also wanted to highlight, there is no, in this CPG, there's no mention of total sleep time. So when we think of treating someone for insomnia, at least my goal would be to increase someone's total sleep time. But from other readings that I did, it seems like there's at least a 30-minute improvement in total sleep time, upwards to 60, but that we may not see that 60-minute improvement until maybe 3 months down the road. So it's not always right after they've completed their CBTI therapy. So the ASM task force for this, for chronic insomnia, they also had additional recommendations, but those were all conditional. So the data to support these recommendations were not as strong as for CBTI, multi-component CBTI. They also talked about how multi-component brief therapies for insomnia can be used, stimulus control by itself, sleep restriction by itself, and relaxation therapy by itself. They can be used, but they're not going to be as exceptional as the multi-component cognitive behavioral therapy. And they also suggested that we not use sleep hygiene by itself. Sleep hygiene is definitely good. I mean, we see it in clinic that sometimes just turning off that TV really makes a difference. But, you know, in the large context, they can't make that as a strong recommendation. So brief therapies for insomnia. Brief therapies, it's basically like CBTI, but a abbreviated version, a shortened version. So CBTI typically is 6 to 8 sessions. And so a brief therapy for insomnia would be 1 to 4 sessions. And, you know, some patients, they don't want to have to come back to a psychologist or a clinician like 6, 8 times just to deal with their insomnia. They want sometimes, you know, give me something quick and easy. And there's no guarantee that it would work, but it can. There are benefits to trying to do at least a short version if that's all they want to do. With this group, the meta-analyses did show clinically significant improvements in the remission rate, responder rate, and sleep quality. And it was based off of 7 randomized controlled trials. So CBTI, these are the different components we talked about: cognitive therapy, stimulus control, sleep restriction, relaxation, and sleep hygiene. So first we will talk about cognitive therapy. Cognitive therapy. So common dysfunctional cognitions about sleep can be classified into 5 categories. So you have the misconceptions concerning the causes of insomnia. That could be addressed with sleep hygiene. You have your misattributions or amplifications of its consequences, unrealistic sleep expectations, diminished perceptions of control, mistaken beliefs about the predictability of sleep. Cognitive restructuring is used to address the sleep disturbing cognitions directly and replace them with more realistic assessments and positive ideas. Right, so, you know, when you think of cognitive therapy, we're trying to address the negative thinking these patients have. And so this is also an opportunity for us to educate patients, you know, on what is normal, what is, how does sleep work, how they can still function sometimes, even if they don't think they're getting as much sleep as they think they should be getting. So this is part of our job. So how do you do cognitive therapy? These are the 4 steps. It's a stepwise approach. So you discuss with patients their beliefs regarding sleep and their sleep problems. You can do subjective rating scales on sleep beliefs, such as the dysfunctional beliefs and attitude scale, and that can be used to help evaluate the patient's sleep cognitions. You identify the counterproductive beliefs, and then enlist the patient as a co-investor to help gather data. So they probably know better, they'll probably know better than us about what, you know, what's really going on in their head. So it's important to get them involved and be a collaborator in their care. And then we provide the correct information to address a specific
Question.
Yes,
Can you give an example of dysfunctional belief?
yes.
Or like, yeah, and then counterproductive belief. Like, I think that would be helpful.
Yeah, so a dysfunctional belief, the patient thinks that they need 8 hours of sleep. And not everybody needs 8 hours of sleep. And so they're fixated on that. And so they're not able to overcome that idea, and that's inhibiting them in a negative way. So by doing something like, and sometimes they might be getting enough sleep, and that's why we do a sleep diary, which even though the patient thinks they're not sleeping, we'll be able to tell from activity, for example, that, hey, you're actually sleeping this much. And then just redirecting them. And then next, sorry, 40, okay. I'll go through this a little faster. So then we have stimulus control. It's a set of instructions designed to extinguish the association between the bed, bedroom, and wakefulness. We'll just get right to what exactly we talk about. So stimulus control, these are the 5 things. You go to sleep only when you feel sleepy. You only use your bed for sleep and intimacy. If you haven't fallen asleep in 20 minutes, you get out of bed and you go to another room and do something else. Nothing stimulating, like light reading or just listening to soft music. And then you go back to bed when you feel sleepy again. If you can't fall asleep again, then you get out again. And then you set the alarm for the same time each morning. The second last part where you have to keep getting out of your bed if you don't fall asleep, that's annoying and irritating to patients because they're thinking they'll never sleep. But they're coming to us because they're not sleeping anyways, right? So why not try to do something that may in the future eventually get them out of this cycle? I'm just gonna keep going here because we have a few more slides to cover. Then we have sleep restriction. So this works by basically increasing sleep efficiency. So the amount of time spent awake in bed versus sleeping. So that's all this is about. One thing about sleep restriction is it does induce a mild to moderate sleep debt at the beginning of treatment. That heightens the sleep drive. So that's the whole point. But it's also important that we know who to use this with, because there are certain folks that this is not a good idea. So it's contraindicated in those who have high risk occupations, so those who operate heavy machinery, drivers, those who are bipolar, who have poorly controlled seizure disorders, because even less sleep can decrease the seizure threshold, and also those who already have excessive daytime sleepiness. And how do you do sleep restriction? I'll go back here. Based off of the sleep log that they provide, you basically figure out a window of where they're going to start. So if they're going to bed at 10 p.m. but they're not sleeping until midnight, then we get them into bed only around midnight. But we still want them to get at least 5 hours. So whatever that is, we kind of adjust accordingly. A simple way of doing sleep restriction is, so you follow the original restriction and then you increase time in bed progressively by 15 to 30 minutes every week until the patient hits about 7 hours. The previous way is you do it based off of what their actual sleep efficiency is. Okay. And then relaxation. So there were 5 randomized control trials that the ASM reviewed that showed clinically significant improvement in the responder rate and sleep quality. Excuse me. These are some examples of relaxation methods. So progressive muscle relaxation. So it reduces muscle tension by sequentially tensing and relaxing the main muscle groups. Autogenic training promotes somatic relaxation by inducing sensations of warmth and heaviness. Biofeedback, we probably wouldn't be doing that in our office. That requires like hookups and heart rate monitoring, EMG. So that's not something that we would do, but it's something that falls under relaxation, and then slow, deep abdominal breathing. I'm just gonna keep going here. And sleep hygiene. So I mentioned this before. Sleep hygiene by itself is not recommended by ASM. They only had 2 randomized controlled trials, and both had low quality evidence. But in conjunction with everything else, it definitely can make a difference. Because I remember just from clinic with Dr. Ye, we had a follow-up patient, and he talked about sleep restriction and sleep hygiene. She didn't do the sleep restriction. She just stopped watching TV, put her phone away an hour before bed, and that itself was enough for her. And there was like an anxiety component as well that was also being addressed, that definitely did contribute. But, you know, these simple things do make a difference.
And she's preaching to her classmates about that now.
Medication also, as you see this list here, just be careful with some patients who have PTSD, history of trauma, because sometimes when they meditate, they may end up going into a darker place. So you want to be mindful of these types of things. I'm just gonna quickly skip over the stuff. I just like physiologies, and sometimes it's good to know, you know, why do we tell people, you know, to avoid caffeine? Well, caffeine inhibits or it blocks our adenosine receptors. Our adenosine builds up over time, that ends up making us sleepy, and then when you have caffeine, that gets blocked. So then the natural drive to sleep is inhibited or is delayed. So it's good to just know physiology, because some patients, they want to know the why, and knowing the why helps them make good decisions about their health. So I think it's nice to equip them with some of this, some of the knowledge that we have. So some challenges with CBTI, adherence to treatment recommendations. So the time commitment, the traveling for, you know, patients who are in different socioeconomic backgrounds, rural areas, that all can impact whether someone goes through a complete CBTI. The fact that it does take time, you know, people need immediate rewards sometimes, and discouragement in the beginning can really put people off and not feel motivated to keep going with it. So this is why it's important that we set realistic expectations with our patients. And I saw, you know, Dr. Ye do this with an insomnia patient that we had last week. You know, just two things for the patient to work on, and they're not really hard things. So, you know, we start small. We give them something that actually would be obtainable. So then, you know, when they come back, they feel encouraged and they're ready to take the next steps. Okay. So alternative forms of traditional CBTI, you know, usually they're one-on-one with a trained sleep psychologist. There's other forms include group sessions, virtual telehealth visits. So Dr. Landis does virtual CBTI. Then there's the digital unattended ones, and then the brief sessions, which we talked about before. Yeah, and so access, and this was another thing when in my residency, we were somewhat in a rural, we had patients who were in very rural areas, and it's not practical for them to come up to the city and, you know, come up for 8 sessions and go through this. So that's why, you know, most people have phones these days, and apps are very nice and handy. Visits can be very expensive. Having 8 visits can be expensive depending on your insurance. So, you know, giving patients tools that they can use at home that could potentially be free or relatively cheap is important. It's important for us to know what those options are. And this will be a conversation we have with the patient. it's important to know what are their values, what's their priority, and then figure out a plan before we just right away send them to an actual sleep psychologist. And so like Dr. Stroll always says, what type of CPAP mask is the best mask? It's the mask that they use. So whatever method people want to do this type of therapy, whatever method they'll do, that's going to be the best method for that patient. Oh, another challenge to in-person visits, especially as clinicians, schedules are booked out for a lot of the docs. And when you do this, you want close follow-up. And if we can't provide that, that's going to be difficult. So it's also good to know, as much as I talked about us doing CBTI, it's good to know what are the other resources when we can't actually deliver. So digital CBTI has been around for some time now. It's been shown to be effective in pregnant women and postpartum women with their insomnia. It's been shown to help with insomnia patients who had a history of TBI. And so there's a 2017 study that looked at a specific CBTI app called Sleep Care. This was just a basic initial study. It was mild insomnia, but there was improvement in their insomnia severity index score and the sleep efficiency. So there are promising things out there. This is just some images of that particular app. These are the exercises that they offered for their patients. And this just shows how there's an improvement in the ISI and the sleep efficiency. So some advantages and disadvantages. Let's talk about the disadvantages first. There's a lack of adherence sometimes when you have these digital CBTI apps. There's no one really keeping the patients accountable. There's overgeneralized advices. They're trying to appeal to the masses, right? But people are individuals where everybody's different. So that's where, having that one-on-one conversation with patients is going to be beneficial, in my opinion. They're not really guided. Most of them, there's no therapist, that's actually checking in and giving real-time feedback to these people. There's privacy concerns, but it is still another tool that is relatively easily accessible. And some of them have really good algorithms. So it is promising. Some limitations or issues with these apps, there's so much out there. And not everything is actually validated. Some of them are going to say, research has shown this method works. Yeah, CBTI works, but we don't know how good their particular app is. So those are things to be aware of. Some people are not tech savvy, so that's going to be a factor. And some patients actually, they're going to be so hyper-focused on the data that their app gives them, which could actually make their issues worse. So the type of digital CBTIs, there's the digital CBTI as support. So we see someone in clinic, we use an app as a supplement to the care we're giving them. So it's something that they're going to use when they're in the in-between time between our visits. Then there's guided digital CBTI, where there's an actual therapist that gives feedback. And then there's fully automated digital CBTI, and those are the ones that have those algorithms. So I did come across this 2021 review of 6 different platforms. So this looked at Sleepio, Shut-Eye, Sleep Rate, the CBTI Coach, which is the VA app, Night Owl, and Mind District. I'm not going to give much a voice to Mind District because it's not in English, so we would never use it. But majority of them use all the components of CBTI, some just 5 other ones. So this just goes through the advantages, disadvantages. I would say in the end, it's going to be what the patient can afford. So no matter how great the images one app has, if it's $400 a year, I don't think some patients would go for that.
Is that about the average price, or is that?
No.
more expensive?
And no, that's the most expensive that I found.
And what was the cheapest?
Free.
Free, okay.
CBTA coach is free.
Okay.
So these are a bunch of different things that are out there on the Apple App Store. CBTA coach, Stellar Sleep, Sleep School, Rest School, Somra, Zen Sleep, Sleep Hack, Somnus, like so many things that are out there. But I do like the fact that the 6 ones that were in that study is actually validated. They did some studies, so that's good. SleepU is about $450 a year. Some employers do offer it, gift-free subscriptions as part of their health insurance plan. Shut-Eye is $150 for a 6-month subscription. Sleep Rate, I couldn't find an actual set price, but I know they have 3 packages, and I think the highest one is the one that has all the components of CBTI. Someone commented saying it's about $100 a year, but I couldn't verify that. CBTA coach is free. That's awesome. Night Owl, it's free to download, and I think just the upgrade for their coaching one is $10, but I couldn't verify that. There were some other ones. So the Go to Sleep, are you familiar with that? The Cleveland Clinic, that's just $40. Somnus is another app. They're $50 for a lifetime. So. Oh. And then these are some other recommendations that ASM does not have any recommendations on these following methods because there's just not enough data. So cognitive therapy by itself, we usually do, it's multi-component anyways. Biofeedback, paradoxical intention. So that's when you tell patient you actually stay in your bed
Try not to sleep.
and try not to sleep.
Don't.
Intensive sleep training, and then mindfulness therapies. Okay, other therapies. I just wanted to bring, we wouldn't do this, but it's just good to know what's out there. Transcranial and direct current stimulation. There's a preliminary study that showed improvement in sleep quality in insomnia patients that were post TBI. Other therapies, blue light blocking glasses. So some patients don't want to watch, they still want to continue watching TV and be on their phone. There was a study that reported, this was the first study to report on the impact of blue light blocking glasses on both subjective and objective sleep. There was no improvement in the subjective or objective total sleep time, but there was improvement in the subjective awakenings in sleep onset latency and objective awakenings. But it was a very small study, only 20 people from Montana and Michigan. This is something else that I think about, spiritual and religious interventions. So that could be anything from having a mantra, yoga, mindfulness, praying, just spiritual experiences. There's not a lot of data out there. There was one article from Spain that talked about there seems to be a positive influence of spiritual religious interventions on insomnia directly and indirectly. But I don't think it can hurt. So I remember a few years ago, Case had a study, not regarding insomnia, but how people who were more spiritual or had a faith background, they were able to deal with grief more than people who didn't have that kind of background. So I think there is something to say to have patients tap into that if that's part of them. So I had a patient on Friday at the VA who we can talk about, and I only ask these questions when I kind of like, what else do I do? I have these suggestions, but it seems like he's going to need a lot of help. So I just asked, do you have a faith background? I'm not pushing anything. And some people, like this particular guy said, nah, he was raised Catholic, but doesn't really practice. But he does go to church for his AA meetings. And I was like, well, maybe you can spend 5 minutes in the chapel or whatever. Just a suggestion. I think sometimes for many folks, that spiritual side does make a difference, especially if there's a lot of anxiety that's driving their insomnia. So I just wanted to put that out there. Some general tips. As clinicians, it's so important that we relate to the patient. We may not be able to relate always, but at least make them feel comfortable, meet them where they're at. When we try to do everything right, I got to do this, this, and this, they're going to be turned off or they're not going to be motivated. So it's really important to kind of understand where the patients are coming from and, cater the visit to them. Build up confidence in them. And then, like I said before, close follow-up is important. So why is non-pharmacological therapy important? One, it can be cost effective depending on the insurance. It definitely reduces the need for medications. There's a lot of studies out there showing how there's a lot of falls in the elderly, cognitive impairment because of these sleep aids. So we're avoiding that when we just focus on non-pharmacological therapies. And you're also not putting a Band-Aid over the problem. We're actually trying to find the root cause and address that. So I don't like Band-Aids. In residency, the IM coordinator, she had insomnia, and so her PCP put her on Balsama, and that night her husband took her to the ER because he thought she had a stroke. Like, she was just not responding, just really out of it. Like, he really thought, she was fine, but it was just because of that medication. So as physicians here, are we equipped? So despite the efficacy of CBTI in treating chronic insomnia, it's still actually underutilized. They say lack of appropriately trained CBTI providers is the main reason. So I have a question. So from fellowship, do we count as professionally trained in CBTI? Or is it just a sleep psychologist that's professionally trained?
Just the sleep psychologist.
Sleep psychologist, okay.
So do you think it's underutilized because of access or because clinicians are different?
I think it's a combination. So access for sure. I know from my program before, patients definitely did not have access. We didn't have a sleep psychologist. We had psychologists, but no sleep psychologist. Everyone would have to travel like an hour to Columbus. And some patients may not want to do it. There's like a stigma. When you think of cognitive behavioral therapy, you think, oh, I don't have any psych problems. Why do I need to see a psychologist? And so some patients, that may be a hindrance. But I did find this online. There's actually a resource for practitioners to be CBTI trained. I don't know. It's probably not, you're not going to get the same level, not going to be as good as a truly trained sleep psychologist. But something is better than nothing. It's not bad. It's an 8-hour course, only $200 for a solo practitioner. So I'm not affiliated with these people. Okay, I'm not trying to advertise for them, but I just found it online. So it is 9 o'clock. I don't know if we have time for this.
They take that curriculum. Yes, they did, didn't they? Yeah, they did.
Yeah, do you have one case that you want to go over?
Yeah, it's for the fellow.
For those who want to stay on, why don't we ask to see if there's any questions
Yes,
and
sure.
then give people a chance to.
I will just show you my.
Do you want to see the chat? To see if
Oh,
anybody's on
yeah.
the chat?
Sure.
Let's take a look. Oh, right up there, yeah. So maybe go up to the top.
Oh, that's what it is. No coffee.
Okay, so-
I want coffee to first, They give you like 2, maybe they have some more coffee. They'll get your-
Yeah, professionally trained.
5 more. You know?
Yeah.
Okay, good.
This is over. I can walk over.
It's actually true. So do we have group, I know Cleveland Clinic does a lot of group therapies. I don't know if does that.
Couples together.
Apps advising us of restriction makes me nervous. I do, yes, because even when we recommend sleep restriction, we need to be very careful about who we're giving that to. Very important point.
So did the apps actually include that in their algorithm, sleep restriction?
So some of them did, so if I go back
realize.
to, here.
Yeah, Suzanne's done a very nice talk and overview. But yeah, that's one of the things, sleep restriction, I think, is something, there's so many pitfalls and risk with it that you really need very close follow-up if you're going to recommend this for a patient. And just having an app do it willy-nilly seems very risky.
Yes, I agree.
Put away your phone, but bring up your phone for the app. I agree, Dennis.
I'd be interested to know in the sleep restriction, like their algorithm, like how far do they restrict? Like, do they actually go all the way to 5 hours? Obviously, I don't expect you for that, but I just would be really interested in like. I would assume they would put safety protocols in there to where you're not being told to like go down that far.
I hope. I mean, I didn't come across like truly harmful data, like any data showing that there's significant harm, but I just don't know if we know.
Yeah, I mean, that just seems like a really big liability, and I did attend a talk, it was one of the TUMS talks, like from Munich. And there was a person a sleep physician that was involved with one of their European apps. And she did mention when they do sleep restriction, they're very lenient on it. Like it's not as strict as if you were to go to the office and be told to restrict that 5 hours.
Okay.
Yeah. So I don't know if that's true across the board,
It must
Honestly.
be,
but
or
it
they
seems like a
gather,
huge liability.
or they gather the appropriate history. I don't know.
All right, so I guess for whoever that's online, if you have time, is still interested in stick around, we'll continue to have Suzanne present this case before we jump to the fellow plan.
So just on Friday, I wasn't planning on including a case, but I had another insomnia case on Friday. So I figured why not? He's an ex-Marine. I saw him on Friday, 67-year-old, history of Pepsi, clear infection, NASH, substance abuse. So he used to be an alcoholic, cigarette smoker, drugs like cocaine, heroin, amphetamine, opiates, like everything. Recently saw a psychiatrist for anxiety, depression, but not on any psych meds. He's had sleep issues for many years, but it wasn't really problematic until a year or two ago. So he's always been, a 4 or 5, max 6 hour sleeper, but it never was an issue for him. He functioned just fine. He was able to, when in his younger days, but now it's actually catching up on him. He has significant daytime fatigue, upwards was 12, but he does take 30 to 60-minute naps that he does find refreshing. He used to have a history of RLS, not anymore. There was no concern for obstructive sleep apnea from the history I got, so we didn't do any additional testing down that line. He has a very good sleep hygiene. Dark room, comfortable bedroom temperature wise, no TV, phone at least an hour before bed. So sleep hygiene wise, he was pretty good. Caffeine, nothing past 12 noon. So his bedtime is around 9:30, 10 p.m. Sleep onset is less than 10 minutes. He does wake up once in the middle of the night to use the bathroom, but then he has no problems going back to sleep. But then he wakes up between 2 and 3 in the morning. He really would like to sleep a little longer, at least until 4 a.m., but he's just not able to. He wakes up with racing thoughts, doesn't have that issue going to bed, but then because of that, is unable to go back to sleep. And he's tried to go back to sleep, but he's not able to do that. Stressors right now, he's a construction worker. So because of his age, he doesn't do anything. And I mean, they still do projects during the winter, but he, by choice, doesn't work during the winter time. So that does add a financial strain. He has to take care of his wife as well, because she does not work. She's disabled. So then he wakes up 2 or 3, doesn't know what to do. He waits a little bit and then goes to the gym at 5 a.m. He says his morning coffee helps calm down his racing thoughts. Not any other medications or stimulants. He wants to avoid meds because of his history of abuse. He's tried melatonin in the past. It didn't work for him. All it did was make him groggy. And then, so 67-year-old sleep maintenance insomnia guy with comorbid anxiety, depression, insomnia, likely secondary to anxiety, recent stressors, negative habits, like his thinking. Advanced sleep-based disorders on the differential, maybe. So my question, I have a question regarding this. He's an early morning riser, but he only goes to bed late. He could go to bed earlier, but he tries not to because he wants to spend time with his wife. Is there a chance that he's advanced?
I think by definition, these events, right? So, I mean, I guess one of the things that I always try to find out is that what time of the day do you feel the sleepiness? You know, like if there's no time during the day when he is awake, sleepiness is bothering him. Or like sometimes they may not express it as sleepiness, they may express it as, you know, inability to concentrate, lack of, you know, whatever, you know, I don't like to use the word energy because, you know, that brings fatigue into play, but, you know, sleepiness wise, is there a reason, does he feel like he's ready to go in the morning when he gets up like 3 o'clock in the morning?
Oh, he hits the gym.
Right.
He's done so many things by 12 noon when his wife is waking up.
Yeah, so the next thing
They're still going to work.
He starts work next week.
Oh,
Yeah.
Right now he's off.
right,
So maybe he comes to that.
And so this
we
is,
don't know, right, but to me, the $1 million question is always like, okay, like you mentioned earlier, do you need that much sleep? Are you doing all right? I mean, what's the concern here, right? So what do you think?
I think the concern is right now he's okay because he's able to nap.
Yeah.
But once he starts his construction job, there are long days where he doesn't really get a break.
Yeah,
So like now he's able to take a nap
right,
and kind of get back, but he won't be able to do that once he starts his job.
but if we were to try to cut out the nap,
Right, so that's what we,
but
that's what I
then
told him.
he might want to sleep earlier. But if he doesn't want to sleep early because he wants to spend time with his wife, then slowly he's going to build up his sleep deficit.
Right.
You know?
Right. So yeah, so I talked to him. He was one of those patients that's fixated on the 8-hour mindset.
Sure.
So I told him, you know, you don't need to worry about that. And the fact that he's getting with the naps, sometimes he does get up to 6 hours. I'm like, that's fantastic. You know, right now you're able to take a nap. That's good. You're still able to do whatever you want to do. So that's also fantastic. He's never sleeping behind the wheel, so there's not a safety concern there. It's only an issue when he starts going back to work.
Yeah.
So this is what we talked to him about. To cut off the daytime napping, I actually suggested pushing his bedtime if he can. That may be a little extreme, I don't know. But if he can, to build up that sleep pressure even further. And then a retrial of melatonin. So he's only starting work next week. So he has this week to kind of play around and figure out what's going to work for him. So either take a timed release, you know, before bedtime, or when he has that early morning awakening, take a regular melatonin, maybe a liquid or whatever he wants. I don't know if it's going to work, but it's something to try. Then we also did refer him to the VA sleep psychologist for CBTI. And this is the guy that I talked to